Good evening. So we are on week 10, in which we are discussing a diffusion of innovation, okay? So let's begin talking about this theory. Perhaps you have recalled over the last couple of years that we have the COVID-19 pandemic. Maybe you have wondered how people have made decisions to either uptake some preventative behaviors or not uptake some preventative behaviors for COVID. So we've seen in media, maybe in our communities, it goes up and down since the beginning of the pandemic, but from the very beginning, who were the people that first began to wear masks? Why other people did not wear masks? What about the COVID-19 vaccine? Even when it was allotted in segments, for example, first healthcare workers, then seniors and other people with at-risk conditions, then middle age and so forth, until we're still vaccinating children. But even with those segmentations of populations, some people within those segments were more likely to want to take the vaccines over others. And what about taking maybe a new medication that is available for some condition? What makes doctors want to prescribe those new medications or do a new type of surgery over the old standard treatment or procedure? So diffusion of innovations allows us to sort of understand people's behaviors, as well as give us some direction about some recommendations we can do to to accelerate the adaptation of innovation. So let us begin with the first. Let's talk about some terminology. So what is an innovation? Innovation is an idea, a practice, a product, a technology that is perceived as new. So it's not necessarily, we can think of it maybe in your mind, you think of it as being like a technology, like an iPhone, for example, but actually it could be like just an idea, a practice, or some other product. So for example, the practice of wearing the masks for a prevention of some communicable diseases. So, and not just COVID, but could be like, the original SARS or the flu. So, for example, in some Asian countries, it was normal to wear a mask. Whenever there's like a flu season or just an outbreak of some communicable disease, it was more normalized over there in those countries. But here, like in Japan, for example, Korea and so forth, but in the United States and in the Western Hemisphere, this was not the normal practice. So for us, this was sort of a new practice, okay? And that's where we see maybe different rates of adaptation to this new, because it's perceived as new by the person. Then we have diffusion, is the passive, untargeted, unplanned, and uncontrolled spread of new interventions. So diffusion just means this innovation is being spread, just like we may say, somewhat naturally, without some specific targeted intervention that is pushing it to be spread. And then dissemination is the active approach of spreading evidence-based intervention to the target audience via determined channels using planned strategies. And as we will see later in this video, I will describe to you what exactly are those communications channels that need to be used per target audience, okay? So let's, first of all, I wanna go over a historical case that shows that highlights diffusion of an innovation. So, you know, for the longest time, there was this disease called scurvy. So scurvy is a disease caused by a deficiency of vitamin C. It's characterized by swollen, bleeding gums and the opening of previously healed wounds, which particularly affected poorly nourished sailors until the end of the 18th century. So back in the day when there were sailors from Europe, and I bet from other countries, sailors were stuck in their ships for, you know, weeks or months at a time. They could only rely on the foods that they had stored in their ships. So for this reason, sailors tended to be afflicted by some diseases that were caused by nutritional deficiencies, because they could only, again, eat the foods that they had. They were relying on those nutrients. And one of these diseases was scurvy. So scurvy is caused by a lack of vitamin C. So what happens is that when they don't have the source of vitamin C, their bodies begin to have some issues that could lead to, you know, from very mild, from fatigue, bleeding gums, joint pain, shortness of breath, to potentially fatal heart problems. So to give you an example, in 1601, Captain James Lancaster, no, before that, I'm sorry. To give you an example, when Vasco da Gama sailed around the Good Hope, the Cape of Good Hope, for the first time in 1497, 100 of his crew of 160 men died of scurvy. So that's 100 men. That's about something like 65% of the crew in that ship died due to scurvy. So this was not something sporadic or something that just happened to a few men, but it was a really costly in human life and resources to navies and merchants. So in 1601, Captain James Lancaster commanded a fleet of 4 ships on their way to India. But in that voyage where he was leading those 4 ships, he told one of the ships there to give the crew 3 teaspoons of lemon juice per day. So somewhat halfway through the trip, about 40% of the sailors in the other 3 ships had died of scurvy, but none died in the ship where he instructed the crew to take 3 teaspoons of lemon juice a day. But even after James Lancaster did somewhat semi-quasi experiment to show that lemon juice could prevent the development of scurvy, no one really paid attention, no one listened to him. So some years had to pass until 1747, when Navy physician James Lind, he again repeated this sort of experiment with other ships and began to provide them with some citrus, and it showed that it was effective against scurvy. But it still took more years until 1795, until the British Navy ordered all these ships to have some citrus fruits available in their voyages. And that was just the Navy. It took another somewhere like 70 more years for the British Board of Trade to mandate all ships, including merchant ships, to carry some form of citrus. Something that is notable is like Captain James Cook didn't wait to make changes. He was sort of known as an innovator. So during his 3 voyages, what he did was I'm sorry. He ordered them to, he ordered his men to eat sauerkraut. So maybe unbeknownst to a lot of people, sauerkraut also contains vitamin C. So he ordered the men to eat this sauerkraut. I don't know how to pronounce it because it's German, but very common here in Wisconsin. But not only that, but he took it himself. He was leading by example. He was showing the officers that they should eat it. And in his voyages, he only lost 3 men due to scurvy. All in all, it took about 264 years for this innovation to be adopted. And I'm sure after this, it was sort of shared with other countries that did not have, that were being afflicted by scurvy. So what are the main factors that affect dissemination of innovation? So for one, processes have their own rules and pace. We cannot compare, for example, the adoption of a new iPhone to the uptake of the COVID vaccine, for example. So each innovation, it has their own rules and their own pace, and it can take a long time to adopt, okay? As I just showed you with the example of vitamin C to treat scurvy. It requires social interaction. So unlike you might think, we don't just take innovations just out of the nothing or just from reading in a book or an article. It actually requires a lot of social interaction, a lot more than you might realize. And again, I'll explain. It is also multifactorial. So there are many factors that affect it, and these factors that affect whether the speed of dissemination occurs, faster or more slowly, can be at various levels, from the individual to the organizational to societal. And again, I shall explain. But why does this matter for us, for public health officials or for healthcare workers? Well, for once, because in healthcare, innovations tend to be hard to create. We're talking about treatments, vaccines, procedures. So it can take a long time to come up with a new idea or new product. And then after that, dissemination can be even harder to do. Even if, for example, I'm still amazed that the COVID vaccine took not as long as other vaccines in the past, but we're seeing like dissemination is still occurring. There's still a proportion of the population that has not taken even the first vaccine and now the booster shot. There's been some trials, for example, in different places where some hospitals take on a new practice, a new idea, and it's shown to work. There are real data to show that it works, and yet other hospitals do not adopt them. So why is that? For example, there was in one hospital, there was some pioneers, gynecologists and nurses who introduced some safety procedures to reduce the cesarean delivery rates from 26% to 15%. However, they remain high for the rest of that hospital system. In other places, again, in other hospitals, we see that some surgeons or some groups intervene and they enact some new treatments or some new step, for example, in the emergency room to prevent rehospitalization. And then they're shown to work, but then they're not adopted by other clinics or other doctors. What we have is that a diffusion of innovation, there are some elements that can influence the diffusion of that innovation. So some of these elements I have here are the perception of the innovation, the characteristics of the people who adopt the innovations, we call them adopter types, and the communication channels that are used, that social exchange, and context, of course, contextual factors, right? So here I have this picture, this graphic of this man, for example, who is wearing a mask. So that could be, like I mentioned, considered an innovation. So first we'll talk about perception of the innovation. So for this, what it means is that for an innovation to be considered a more likely product that people will want to adopt, they need to consider cost. So for this, what cost means is not just, it's the financial cost, but it's also, for example, other costs like our time and resources. It could be pain. For example, if you think about the vaccine, if it hurts and people maybe don't want their children to hurt, unfortunately. So they may see that even though it's a short-term cost, for a long-term cost, it's cost nonetheless. So people will look at the cost of that innovation and compare it. They can compare it to the previous cost and say, is this worth it? Okay. Or, is this something that is worth for me engaging in this new practice? The second, so here we see, for example, the cost, and I'm giving you the example of using sunscreen lotion to prevent skin cancer, okay? And I'll talk about the different modalities. So the second perception of innovation is the relative advantage. So people will try to think, well, what is the advantage for me to using some product versus either using the previous product available or treatment, or using no product or no treatment at all? That is always an option. So people will say, for example, in California, it's more common that there are programs that try to get people to wear sunscreen lotion every day because it's sunnier than here in Wisconsin. So some people will say, well, what is the advantage for me to using sunscreen every day instead of not using sunscreen? I mean, isn't it just safe? And so we need to explain that what is the gain? What people stands to gain versus the cost, okay? And of course, the advantages need to be higher than the cost involved. And then it's also relative advantage to other products. So you can think about somebody's already using it, but may think, well, is it better to use a spray than the lotion? Because maybe some people might say, I don't really like the lotion, it's too creamy, I don't like it. And so then you can have different products, different ideas, different treatments, and offer that advantage to them. Then the next concept is simplicity, is the degree to which the innovation is easy to understand or adopt. So how easy it is for the adopters to understand this product or this evidence-based program? Or do they need some type of steep learning curve or some training? Again, I'm giving you just the example of sunscreen lotion, but here we can also think about more complex scenarios, like adopting a treatment at a clinic, for example. Would you need, how can you make it easier for the clinic staff to adapt? The harder we make it, the more steps, the longer the diffusion of that innovation will take. So there was a case in a hospital, for example, where there was a new treatment. I forget if it was for asthma or for they gave the head nurse a manual that was super thick, and the nurse read the manual, and she saw, oh, actually there are only 2 main steps that we need to take that are different from our normal everyday procedures. And she simplified the procedure to focus on those main 2 differences. And that simplified that dissemination of innovation, and it made it easier for that clinic staff to adapt. So always try to make it as simple as possible. And compatibility is the fit of the innovations with the intended audience in order to accomplish the desired goals. So how much will an evidence-based program disrupt the existing routine? This happens at the individual level, at the consumer level, participant level, but also at the group level, at the organization level. So somebody may say, for example, you can have like the children say, well, how compatible is it for me to carry a sunscreen lotion when I go to school or when I go to the beach with my friends? And so you need to think about making this product as compatible with the target audience's life. So for example, having this this sunscreen lotion that has the little holder so people can put them on the kids' backpacks or in people's or teenagers' purses, for example. So trying to adapt the product. So that's the other something else that you need to note about an innovation is that it doesn't stay stagnant. You can make adaptations as you go in order to facilitate the dissemination, okay? The next one is observability. So it's the extent to which outcomes can be seen and measured. You have a greater likelihood of success the more the innovation is being able to be observed by others, especially by leaders. So, for example, in some schools, you might want to show the teachers putting on the sunscreen lotion as they're coming out to play in the yard or as they're going on a trip to the beach. In the same way, you might want to have not just the teacher, but you might want to have some of the main peers, some of the main kids that maybe other kids follow, actually show that they're putting on the lotion. But it needs to be observable, okay? You cannot just expect and say, okay, they will watch. No, make it observable. Actually make some time to showcase that the product is being used or is being done. And then trialability. Trialability is, giving the target group the opportunity to try the product before they commit to the full adoption. So this, we're used to different products, of course, like cell phones and other products like that. But for example, we'll go back to this little case of the sunscreen lotion, right? That has the little holder. This can be a trial product that we give out at schools or workplaces so people can try that product, and then we hope eventually they can buy more, or if we keep giving them, hopefully we don't need to keep giving them this, but they can continue to use the sunscreen lotion. So those are some of the concepts that affect the people's perception of the innovation. So these are some ways in which you can increase the chances that they will adopt the innovation. Now we have the characteristics of the people who adopt the innovation or do not adopt the innovation. So the categories of adopters are innovators, early adopters, early majority, late majority, and laggers. And I will describe one by one to you. So, okay. So this model, this model comes from is a study from 1943 that looked at the rate of adoption of a new form of hybrid seed among Iowa farmers. The roots of this the diffusion of innovation actually come from in agriculture and having adapted to public health and other areas. So I will describe each one here. Let's start with innovators, okay? So who are the innovators? Okay. So innovators are the 2.5% top of the people in a group of people in a country. These are distinguished from the rest of the population because of their venturesome, so they tend to be more adventurous. They tend to be more tolerant of risks. They're more fascinated with novelty, and they're more willing to sort of like leave the village, to travel, to experience. And so they may invest in more energy in those remote connections. So, for example, they in a study in Colombia, they found out that innovators tended to leave their villages about 30 times a year. So that was a lot more than the average person who left maybe less than one time a year, who left the village less than one time a year. So they tend to be a little bit disconnected from the rest of society. People, they're not really leaders in a way. They're not really opinion leaders. They're not really out there, we might think of them. For example, I have the example here of Marie Curie, who was an innovator, but you know, a lot of the time she was working from her laboratory. I mean, there were instances in which she came out to try some of her experiments, even in the line of war. But for the most part, she tended to be, you know, more kept to herself, being in the laboratory, being a professor. She did go to some conferences with other innovators, but they're not maybe as invested, let's say, with others. In fact, some people may think of him as being like outsiders or kind of weird, but it is that personality type that makes them great to create new, to come up with new ideas. Now the next group of people here, and each of these groups is separated by about one standard of deviation. Okay, so that's how these groups came about. Okay, there's 5 standards of deviation. So the next group is early adopters. So they tend to comprise about 13% of people, and they stand out. They're different from innovators. So they're considered what is called opinion leaders. They are locally well connected. That means socially. They do not tend to search quite as widely as the innovators, but they tend to be in contact with the innovators and with each other. So they listen. They are sort of on the radar, listening and learning directly from the innovators, and then they select the ideas that they want to try out. They communicate with other people around them, with other early adopters. They tend to have more resources and risk tolerance to try new things. And they tend to test different innovations and then report. And they say, oh, I like this one better than another one. Okay, so for example, in healthcare setting, they tend to be elected leaders or representatives of a clinical group. So they may be in some board, for example, or some committee. So they tend to be more in, how do you say, higher up in the administration offices or in some other circle of influence. The next group, so early adopters learn from innovators directly, and they're more open to trying new ideas. And then we have the early majority. So the early majority watches the early adopters, okay? The early majority tend to be more local in their perspective. So whereas early adopters are more likely to take risks and to travel and to try new things and to listen directly from the innovators, the early majority are more local. That means they learn mainly from people they know well and rely on personal and rely on personal familiarity more than science or theory before they decide that they want to, change something. They tend to be a little bit more risk averse than the early adopters. And but the early majority are still more ready to hear about innovations than, of course, the late majority and the laggard. However, they care more about innovations that are relevant to current local problems instead of just general background improvements. So, for example, we might think of the early adopters as being, those are the first in line to try a new product. They just heard about it, they've been waiting for it, they've been reading about it, and they go in line, they stand in line right before the doors open. But then the early majority sort of like, it's more like waits a little longer and thinks more about what are the issues affecting them locally, and waits to hear from people that they are familiar with a little more about the product. So, for example, farmers tend to accept more innovations from other farmers that are having similar practices as they are. Physicians in the early majority tend to try out innovations from other physicians, but also that address their specific needs and not just in general. The next group is what is called the late majority. So here we have the early majority look towards the early adopters, but look towards the early adopters to know whether it was safe to try, and they may just try one product. The late majority actually does look towards the early majority. So, but they will adopt the innovation mainly when it has already been adopted by, as the curve says here, by at least half of the people or more. So they will not, engage and just try out new different innovations. No, they will wait until it's becoming more common, or the status quo or the standard practice, for example. So even physicians will watch and see if once other physicians have adopted and it's becoming more like the norm, then they will be more likely to engage in that new practice. They watch for local proof. So they don't believe that remote proof that, some scientists wrote a paper about it. Rather, they want to hear about the experiences of other doctors or other people who did that treatment. So they watch for local proof. Okay, so they may be more likely to be persuaded if they go to a conference and hear about their peers talking about that new treatment. Okay, instead of just receiving a paper saying, hey, read this article about this new treatment. And then we have the laggards, is the last group. The laggards are the 16% of the individuals for whom the point of reference is the past. So you might think about them as being more traditionalist, or more past oriented. But do not confuse them with being retrogrades. Laggards actually value wisdom. Okay, so I have to say, I consider myself a laggard. So laggards are more traditionalist. They're seen as anchors. So they tend to emphasize more making choices that are wise and useful to the community or organizations. So for example, they tend to be the physicians that will swear by what has been tried and shown to be true and effective. Okay, time and time and again. They will continue to do their practice that they know works. How can the laggards be convinced? The laggards will change again when it's sort of become the norm, when the innovation has been adopted by the majority of the population, and when they are receive those information from somebody who is close to them, who they can trust. That is the main communication channel. It has to be like their best friend, their collaborator, who they listen to, a doctor, and someone of a pastor, someone of real influence to them personally, can get them to change. So I do want to emphasize again that being a laggard isn't bad. Okay, don't confuse being an innovator or an early adopter with being good, and laggard with being bad. These are just different ways in which people adapt innovations. So a laggard, for example, you can see, I've seen, for example, that there was a new medication that came out to treat, I think it was high blood pressure recently. Well, no, some years ago. And I remember that the doctor prescribed it to my dad. And my dad started taking it, but he told me, I don't feel good. Actually, I feel like dizzy, it just doesn't feel good. And I thought, oh, my dad, why he doesn't want to take a new medication? It works. There's been research studies, just take it. And so I told my dad, well, why don't you talk to your doctor? Maybe, you can go back to the other medication you were taking before. So he did. He stopped taking that one. He went to the doctor. But I thought, oh, he doesn't want to try something new. Well, a few months later, it came on the news that that medication was raising the risk of some heart disease or some heart attack or some consequence. And my dad said, see, that's what I was feeling. And look at what happened. And it was recalled from the pharmacies. So laggards wait longer to see that it is safe, that it is okay, and they want to hear from people that they know that it works. Okay, so being a laggard isn't always bad. Here we have a quote by Einstein that says, we can't solve the problems by using the same kind of thinking we used when we created them. So I brought this quote because in general, when we're talking about innovations, they tend to come from external change agents. That's what is called, what is referred to in the book. Usually people who are from within the organization or that system cannot have the same mentality, because we're told what the rules are, we're following the rules, at least a lot of us. And so it takes somebody externally to see the whole process and to say, hey, maybe this could work better, generally. So what are other contextual factors that need to be taken into account is organizational or social systems. So some systems are more likely to lend themselves to disseminate an innovation than others. And I will give you some recommendations on how to do that. The social norms, of course, need to be considered with disseminating an innovation. Then I spoke about external change agents. Leaders matter. So leaders, for example, who favor innovation or who can support staff to come up with innovations or to adopt innovations, are more likely to accelerate the uptake of that innovation or the adaptation of the innovation. And then also favorable communication relationship. So as we saw when I described the different adopter types, communication between these groups matters. And don't rely just on social media or again, or an email. We need more, some groups require more impersonal communication than others. So we need to establish ways in which people are able to meet and to talk. For example, here we have in the picture like places where people can meet in the hallway and have a conversation about what they're working on, for example, are more likely to create innovations and to spread innovations because they're talking here in there by the water, they're having side conversations, than maybe other places where people are just separate, everybody's working remotely from home or working separately in their own offices and people don't talk to each other. That environment is not conducive to disseminating, to creating innovations or disseminating innovations. So what are some recommendations for accelerating the dissemination of innovations? And I have some recommendations based on Berwick's article on disseminating innovations in healthcare. So the first rule that he has is find sound innovations. So in general, healthcare is kind of unique, stands out from other fields in that in healthcare and in health, we do publish our work on innovations. It comes on journals. It takes a long time to publish, it could take a year or more to publish an evidence-based practice. But even when it is published, many hospitals, many clinics or small practices may not be scouting for these articles, purposely scouting for innovations, okay? They may just come and not be missed, okay? So the first step is to find sound innovations. That means that maybe somebody in that organization need to be assigned the task to purposefully surveil the field, surveil articles, survey reports for innovations, okay? So that is the first recommendation. The second one is to find and support innovators. So like I mentioned before, novel answers, they don't tend to come from the inside, they tend to come from the outside. But also innovators, like I mentioned before, tend to be more like traveling, because kind of this traveling and experiences tends to stimulate creativity. So if there's a way to support some of the people who have these characteristics in order for them to create innovations, we should do that, okay? So it may be, for example, providing staff with some time, allotting them some time on their own to think, sending them to conferences, allowing them to go on trips, giving them a year of sabbatical and some financial support so that they can come up with some creative solutions to problems, okay? They may want some latitude. They may not want to, go by the rules. The third one is invest in early adopters. So there is kind of a balance between encouraging compliance of existing rules and then encouraging change and supporting new practices. Okay, there's sort of this balance. So in some way, we do want to have some, of course, some rules, but at the same time, we need to invest in early adopters who want to test some new innovations. So like I mentioned, they tend to be the ones who kind of test 2 or 3 different products or ideas. So you want to give early adopters some leeway, some time, and some resources to test new innovations. Okay. And again, giving them some time to explore that, and it must match their personal or their professional interest. The number 4 is to make early adopter activity observable. Okay, so as I mentioned before, observability matters. So making the early adopter observable to the late adopters, okay, can accelerate the uptake of the practice. So let me see. So this is the crucial interface between the early adopter and the early majority, as well as between it's more crucial between early adopter and early majority, okay? And then trust and enable reinvention. So like I mentioned, the example with the sunscreen lotion that changes to like a spray or to some other modality. The same can happen with any practice. Eventually, during the dissemination, maybe the product is changed, it's adapted, and that's normal. It is the normal process that happens to many products when they come in the market, is that, so you need to trust and enable reinvention. So maybe something needs to be adapted for a specific hospital or community, and that is okay. Maybe nobody ever thought to use a certain product in a certain way, and then it changes, and then more people adapt it. Create slack for change. So that means allow people to take the time to test those discoveries. That means the early adopters to test those discoveries. Allow the early majority to network with the early adopters, okay? And then the late majority, allow the late majority to monitor the current status of the adoption of the innovations, and then allow the laggers to maintain in contact with some of their key points of reference in order for them to get that opportunity to adopt that change. And then lead by example. So leaders who champion the spread of innovations must be prepared for resistance or sometimes even ridicule. But when a leader engages in that change, but role modeling, the followers are more likely to adopt that innovation. So we saw during when the COVID vaccine came out that some of the key representatives, some popular people in the media were doing pictures and, how do you call it? Were getting pictures, or were getting the spotlight on the news that they were taking the COVID vaccine. That means leading by example, so that other people are more likely to take it. So now I just explained to you just in general, the theory of innovation and the different types of adopter categories, as well as the communications channel that need to be targeted for each, and so forth. So for the discussion this week, there are 3 questions listed in the blog, and one of them is, I would like you to consider, how would you approach one adopter type about taking the COVID vaccine? Okay, But you can practice in your mind. How would you approach each adopter type about using the hand sanitizer, the mask to prevent transmission of COVID, or doing the COVID vaccine? For the blog, I only ask about the COVID vaccine. And you need to be specific about your communication channel. So don't tell me in general, or a friend will tell them. No, say a teacher, their peer teacher will tell them, or their peer medical professionals at a conference specific for this issue or whatnot. So need to be specific about the communication channel, or it could be something on social media by high schools. So you need to be specific about the adopter type, specific about the target group, okay? If you're targeting young people, adults, older adults, men, women, are minorities, and then you're specific about your communication channel. If you have any questions, as always, please contact me at adelgado@mcw.edu. So thank you very much to let me know if you have any questions, okay? Have a great week.